Bryan Jordan from Infirmary Health is here. Dr. Jordan, thank you for stopping by.
Thank you for having me.
We were just talking about the advancements that have been made in imaging technology as it relates to breast cancer and mammography. We were talking about the difference between 3D and 2D. Go ahead and explain again the difference between those two.
So a traditional or a 2D mammogram is essentially just like looking at this plant in the background we have here. You can see that it's a plant, you can see the leaves, but it's what's hiding behind the leaves that we can't see. With 3D mammography, its images are taken through the breast at 1 millimeter slices, so we can see beyond the leaves and detect cancer at its earliest form.
Okay, and so, kind of walk us through what a radiologist is looking at and how much can they see in those images?
So, what a radiologist is looking at in a daily work day, each image or the set of images that are obtained to the breast are taken in 4 different projections. Each one of those image sets encompasses about 100 images, so 400 images in total per patient. Those are 1 millimeter slices through. What we're looking for is speculated masses, calcifications, areas of tissue distortion. Anything that is remotely suspicious, we'll call it back, work it up, because our goal is we want to find cancer at its earliest form. Right,
and on that note, sometimes the guidelines change. How often should a woman make sure that she's getting that preventative screening is really what I call it?
I like it. That's wonderful. That's exactly what it is. It's being proactive. So, without any additional risk factors whatsoever, 40 years old and annually screening mammograms. Now, if patients have additional risk factors, they may need to start screening sooner, especially in African American patients, as their outcomes are with far more aggressive cancers and worse outcomes overall.
And they would know that. That's something that would have been brought up by maybe a primary care physician?
Correct.
Okay.
So the intake and the assessment is done in the patients anywhere from 25 to 30 years old, a risk intake, and then that cues up earlier screening if it's indicated.
Okay, I want to talk a little bit too about the breast cancer center at Infirmary. Can you kind of walk us through some of the new things that you guys have going on there also?
We have the newest and greatest technology available to our patients. We're fully 3D. Every patient that walks in our door gets the best that we offer, which is 3D imaging. We also have contrast-enhanced MRI, we have contrast-enhanced mammography, and we have a whole breast ultrasound. So everything that we need to find cancer at its earliest form. Our goal, if we're doing our jobs right, is to find cancer at stage 0, 1, or 2. Based upon the American Cancer Society's decades and decades of research, within those stages, patients have a near 100% survival.
Yeah, last question. You've got 2 events that are coming up. One's going to be in Fairhope and another opportunity in Bay Minette.
Correct. So the Lunch and Learn.
Yes.
So it's an outreach to the public. I'm going to show a series of cases and images, talk to people, field questions, and just be available to answer anything I can and make it easy for people.
That's awesome, because it can be scary when you get that diagnosis, even if it's just 1 or 0%. To hear it is alarming.
Right, and that's why we take the opportunity in our breast centers where we talk to each patient. We explain to them, unfortunately, if it is a patient that has a new diagnosis, we try to frame it in the context of which it was discovered. If we're finding cancers that are 1 centimeter or less, the nodal survey is negative. Again, the presumption on anatomic survey is a patient is an earlier stage. Stage 0, 1, and 2, near 100% survival. It's not something you want to tell any patient, but if you put it in that framework, it takes down a lot of the hit and the sting.
Yeah. Thank you so much for stopping by.
No problem. Thank you.